Good evening. My name is Dane Hayworth. I'm a physiotherapist. I work in Craighall Park and do home visits in the north, east, south, and center of Johannesburg. I'm going to be speaking today on managing muscle and joint pain with axial spondyloarthritis. So I'm not Miranda van Dam, I'm just using her Zoom. So that's why it's got my name as Miranda. I'm Dane Hayworth. So this is the talk. I'm just going to be sharing the screen. So, managing joint and muscle pain for axial spondyloarthritis. Let's first establish what it is. Axial spondyloarthritis is a seronegative spondyloarthritis of the spine and pelvis. The term axial spondyloarthritis has only been used since 2009, when the Assessment of Spondyloarthritis International Society axial spondyloarthritis classification criteria was developed. The ASAS criteria allowed for the first time earlier identification of axial spondyloarthritis through magnetic resonance imaging, which is MRI. So what is axial spondyloarthritis? It is used to describe patients who have non-radiographic and radiographic axial spondyloarthritis. Non-radiographic axSpA does not show an X-ray, but there are changes on the MRI. Radiographic axial spondyloarthritis is also known as ankylosing spondylitis, which is an older term. Axial spondyloarthritis predominantly affects the spine, with inflammatory changes causing pain, stiffness, and a loss of motion in the back. It often causes changes in the sacroiliac joints, apophyseal joints, costovertebral joints, intervertebral disc articulations. It causes characteristic inflammatory back pain, resulting in structural and functional impairments and a reduction of quality of life. So, affected joints progressively can become stiff and sensitive to a bone formation at the level of the joint capsule and cartilage. It causes a decreased range of motion, and at its advanced stages can give the spine an appearance similar to a bamboo. Hence the alternative name, bamboo spine. As you can see in the picture over here, you've got the healthy spine, you've got the inflammation at the cortex of the bone and at the joints, and then the fusion of those joints causing a bamboo spine in ankylosing spondylitis. Although not often recognized, axSpA can also be causing pain and joint pain peripherally in the hips, knees, ankles, shoulders, and neck. It involves synovial and cartilaginous joints, as well as sites of tendons and ligamentous attachment. Early diagnosis and treatment help to control the pain and stiffness and may reduce or prevent significant deformity. Pain in AS can be caused by sacroiliitis, enthesitis, and spondylitis. Initially, the sacroiliac joint situated in the lumbar part of the back, which is your lower back, which connect the spine and the pelvis, are damaged. Subsequently, the inflammation moves to enthesis, where ligaments and tendons integrate into the bone. So that would be in your knees and your ankles and your shoulders. Eventually, the spine is affected by this inflammation. The vertebral column normally exists of 24 vertebrae joined together by ligaments and separated by intervertebral discs. Patients diagnosed with AS form calcium deposits in the ligaments between and around the intervertebral discs. An accumulation of these deposits leads to ossification starting from the vertebral rim towards the annulus fibrosis and characterized by syndesmophytes. Syndesmophytes are one of the main features of spinal structural damage in ankylosing spondylitis. It is an osseous excrescences or bony outgrowths from the spinal ligaments as they attach to adjacent vertebral bodies. In highly advanced cases, the spine can fuse together as a result of the bone formation. So the epidemiology, AS affects 0.1 to 1.4% of the population. There's a male to female ratio of 2 to 1 for a radiographic axSpA, and 1-to-1 for non-radiographic axPAR. Onset of symptoms usually occurs between 20 and 40 years of age. Less than 5% of cases have an onset of symptoms over the age of 45. AS is more prevalent within Europe and Asia and Latin America and North America than it is in Africa and India and the rest of Asia. But just going back to that slide, as you can see, South Africa has a higher representation of Europeans than the rest of Africa. So there's more of a representation of AS in South Africa compared to the other African nations. Epidemiology, etiology. The etiology of AS is not fully understood, although a strong link has been established to complex interactions between genetic background and environmental factors. Studies have shown factors such as genetic background called the gene HLA-B27, microbial infection, and endocrinal abnormalities and immune reaction related to the occurrence of AS. In addition, a direct relationship between AS and the major histocompatibility human leukocyte antigen HLA-B27 has also been determined. The exact role of this antigen is unknown, but is believed to act as a receptor for inciting antigens leading to AS. HLA-B27 occurs in 90 to 95% of patients with ankylosing spondylitis, compared to 6 to 9% incidence in the normal population. Environmental or bacterial factors can also be a trigger. So what is the characteristic presentation of inflammatory back pain? Inflammatory back pain should be considered if 2 or more of the following features are present. Additionally, the presence of 4 of these features is considered diagnostic. Insidious onset, which means it starts out of nowhere, in the sacroiliac joints, which is the joints at the bottom of your back, where your pelvis meets your back, and gluteal regions presenting as alternating buttock pain, which progresses to involve the entire spine. An age of onset of less than 45 years, duration of more than 3 months, morning stiffness lasting greater than 30 minutes, waking up in the second half of the night due to pain but easing with arising and movement. Pain and stiffness increases with inactivity and improves with exercise. The patient is a young adult, 15 to 30-year-old male, presenting with a gradual onset of pain and stiffness of the lower back. Initially, the stiffness may be noticed only after a period of rest and improves with movement. Pain tends to be worse at night or early in the morning, awakening the patient from sleep. So more characteristics are more specific to the AS. The following clinical features may be described: involvement of peripheral joints, eyes, skin, and the cardiac and intestinal systems. Eye disease occurs in 25% of patients as either iridocyclitis, cyclitis, or conjunctivitis. Joints other than those of the axial skeleton, which is joints other than your skeleton, than your spine, can be involved with inflammatory arthritis and synovitis. The hips, shoulder, knees are commonly and most severely affected of the extremity joints. Complaints of intermittent breathing difficulties due to a reduction in chest expansion. This reduction in chest wall excursion, notably less than 2 centimeters, can be characteristic of AS because the chest wall excursion is an indicator of decreased axial skeleton mobility. Intermittent low-grade fever, fatigue, or weight loss can also occur. Ankylosing spondylitis and axial spondyloarthritis, what's the difference? In 2009, the Assessment of Spondyloarthritis International Society, ASAS, developed classification criteria for axial spondyloarthritis that was supported on these imaging, clinical, and laboratory criteria. Implementing these criteria, the diagnosis is established in persons who have had back pain for 3 or more sequential months prior to reaching the age of 45 years, with the presence of sacroiliitis, sacroiliac pain, confirmed on MRI or plain radiography, and have a minimum of 1 of the clinical or laboratory findings that is characteristic of spondyloarthritis. Alternatively, individuals with history who have positive tests for the HLA B27 and 2 symptoms of spondyloarthritis as identified on clinical examination or laboratory analysis also meet the criteria for the diagnosis of axial spondyloarthritis. In summary, as stated by the ASAS criteria, the diagnosis of axial spondyloarthritis comprises 2 subsets: non-radiographic axial spondyloarthritis and classic ankylosing spondyloarthritis. Spondylitis, that is radiographic axial spondyloarthritis. Complications. So what else can happen? Fractures following minor trauma due to osteoporosis, usually compression fractures, can happen. Uveitis, which is an inflammation of the eyes. Reduced flexibility, pulmonary function restrictions, increased risk of heart disease, aortic insufficiency, aortitis, angina, pericarditis, and cardiac conduction abnormalities, fatigue, and gastrointestinal disorders. So the medical management is under the guidance of your GP or even better rheumatologist. They will give you the following. First-line drug treatment is NSAIDs, which is anti-inflammatories. Second-line drug treatment is corticosteroids and DMARDs. So salazapine is a drug that I'm sure many of us have been prescribed, and that is a DMARD. And then biologic medication is the third line. I'm not going to go into the medical management a lot because that is something that a rheumatologist or a GP can cover in a talk. I'm going to be talking a lot about the physiotherapy management and self-management. So physiotherapy, there's various factors that are going to help someone when they are battling with AS. You need to have therapeutic. So let's start with modalities. So modalities is what we use to treat. That is joint mobilization, nerve mobilization, muscle releasing, it's ultrasound, it's TENS machines, it's exercise. So it's various things that physios are using to help you with your pain. There's education. Then there's teaching you about your condition and how it affects you and how movement is important for it. Educating you on how to manage your pain. Then there's therapeutic exercises that help manage your pain. There's behavior modification like ergonomics and how you change your position in your car, what type of car you drive, all of that. Joint mobilization, which I've already mentioned. Breathing exercises, soft tissue mobilization, which I've also already mentioned. And then hydrotherapy, which is exercise in water, warm water, which is very good for the condition. So physiotherapy management is essential part of the treatment of AS. It aims to alleviate pain, increase spinal mobility and functional capacity, reducing morning stiffness, correct postural deformities, increases mobility, and improves the psychosocial status of the patients. According to a Cochrane review completed by Dagenfriend and colleagues, a supervised or individual home-based exercise program is better than no intervention. The main aspects of rehabilitation include education, a program of personalized exercises, and an outline of physical activities to be completed at home in a group-based environment. So you've got soft tissue mobilization, which is what the physio will do, or you can do it yourself with a roller, or you can go for a massage. Now, this is a topic where we need to talk about because there are some people who flare up after a massage, and there's other people that feel amazing after a massage with their Axspa. So you need to go on what you work best with. If you need to see a physio rather than going for a massage, see a physio. If you can save some money by going to a massage that is cheaper than seeing a physio, go for a massage if it helps you. If you are able to do self-massage and self-release with a roller, do those things. So it's about what's finding best for you and then doing that. Heat packs are very important. It wasn't mentioned there, but it is a modality. Heat is a modality that we use to treat joint conditions. So you'll notice that your axial spondyloarthritis will get worse during winter. If you put heat packs on your joints that are particularly troublesome, it can reduce a lot of the pain that we experience. Especially a nice one is this neck one that the lady has. And doing that over other joints as well, wrapping it around the joint, warming it up, and getting it moving better. So heat loosens up sticky stuff in the joint, which is synovial fluid, and it allows it to move better so that the joint can move better. Okay, then you've got therapeutic exercise. So you've got mobility and stretch exercises. So you've got strength exercises and aerobic and cardio fitness exercises. So all three of these are important for axial spondyloarthritis. It's doing all three. It's not just doing one. So mobility and stretch would be exercises like stretching and yoga. Strength would be Pilates and gym. And aerobic and cardio fitness would be walking, stair climbing, cycling, playing a sport, and rowing, etc., etc. Then neural mobilization is very important. The picture didn't come out very clearly, but lying on your back and kicking your knee up and down repeatedly and also pumping your foot can glide the nerve. It's something that the muscles are often responding to what is happening in the nerve. And when we release the nerve in our leg, we can release a lot of the tension that the muscles are feeling. So that's just a tip. You can come and see me for a session or see your physio for more guidance about sciatic nerve glides or other nerve glides like in the arm, the radial, ulnar, or median nerves. But that is something that can be a bit of a breakthrough in treating your axial spondyloarthritis because the nerves also get pinched when we have tight joints. And if we can move our nerve, it can also release some of the tension in the joints. Then we've got proprioceptive exercises, which are balance exercises and stability exercises. So Pilates type exercises, they can be very helpful because they provide a structure around the joint which stabilizes the joint and doesn't allow it moving too much. So it provides its stability through muscles, which are then supporting the joint instead of the joint going stiff with those osteophytes and the formation of the bony connections of the joint that then fuse a joint. You want to rather have muscle supporting your joint than your joints fusing from weakness and wanting to form stability in that way. So try and do some balance exercises and some exercises on all fours and bridging exercises are all proprioceptive exercises. Then it's very important with exercise to follow the traffic light system. That mild pain during an activity is fine, providing it settles within 24 hours. So 0 to 3 out of 10, pain while you're exercising is fine. If after you've exercised and it goes up to a 4 or a 5 and then to a 6 or a 7, then you've overdone it. You need to learn your body. Some people can manage to exercise with 4 or 5 out of 10 pain while they're exercising, but it settles afterwards to a 3 out of 10 and then it goes away. Other people, when they exercise, they get a 6 out of 10 to a 10 out of 10 pain, which is way too much and you must stop. So red being stop, orange or amber being proceed with caution, and green mean keep going. So it means that the whole thing about exercise is finding what exercise works for you. I had a patient recently who also has axial spondyloarthritis, and she started Tai Chi, which is a very calm martial art, very good for neural mobility and good for stretching. But it does provide a meditative aspect, and we'll talk about that later when we come to mental health and how chronic pain can affect our mental health. But it is something that is allowing her to move, but not too excessively, because she gets flared up if she tries other things. Hydrotherapy is another one that she does, which is very calming on the joints, but gets you moving. Some people like me, I can manage to run. I play soccer and I run. So I have a milder form of AS. So, but in the beginning, when I was not medicated, I would go for a run and I would have a muscle tear. I'd go for a run and I'd have extreme pain. So only when I went on my medication And that's why I mentioned the medication earlier, because we work as a team. The medication works with the physio, with the ergonomics, with the changing of your pillow and your sleeping position, with your sitting position. It works with your managing of your stress and your anxiety. So all of these things work together for your wholeness. So education is important. According to a study by Sweeney and colleagues, education into long-term home self-care has proven to be effective. Studies have highlighted how limited education and information can result in poor adherence to rehabilitation. Self-care and educational packages, including education booklets and videos, reminder stickers, and progression charts. The failure or success of exercise programs is determined by compliance with the prescribed program, which requires motivation, participation, and time. This can be monitored using patient diaries or physiotherapy records or even apps. So as you can see, there's a whole bunch of stretching exercises that are good for ankylosing spondylitis, a whole bunch of aerobic exercises, and I can send this presentation to you so you can follow it. And then there's pulmonary exercises, which is breathing exercises, which help with the expansion of the chest, but can also help with calming the nervous system down and reducing stress and anxiety, which tightens muscles. So here's talking about chest wall expansion. So most people take short, shallow breaths into their chest. It can make you feel anxious and zap your energy. With this technique, you'll learn to take bigger breaths all the way into your belly. So let's do it together. Get comfortable. You can lie on your back in bed or on the floor with a pillow under your head or knees. Or you can sit in a chair with your shoulders, head and neck supported against the back of the chair. Breathe in through your nose and let your belly fill with air. So now we are really trying to engage the diaphragm and breathing diaphragmatically, which your diaphragm is sitting underneath your ribs and you breathe down and out. So breathe in through your nose and out through your mouth, and you're going to fill your belly with air. Place one hand on your belly, place the other hand on your chest. As you breathe in, you want to feel your belly rise. As you breathe out, you want to feel your belly lower. You don't want your chest, the hand on your chest, to move. Take 3 more full deep breaths and breathe fully into your belly as it falls and rises with your breath. Then there's another type of breath called the longer exhale, which has been shown in studies to decrease anxiety and increase the ability to sleep better. And also calm you down. So this is something that we're just going to go through. Take a few deep breaths in and exhale fully through the mouth with the intention to get present as you begin your movement practice. Focus on your breath as it passes through the nostrils, and then try exhaling the air from your lungs with pursed lips. So that slows the breathing coming out of the body, because the slower we breathe out, the more relaxed we're going to be. Because when we're in a rush or when we're anxious, we breathe shallow and short breaths. So begin to intentionally take longer exhales to get used to the feeling and sensation of what it could be like. Breathe in through your nostril for a count of 1, 2, 3, 4, and then breathe out through pursed lips for 1, 2, 3, 4, 5, and 6. Be mindful of your capacity, so that your next inhale is not as a big gasp of air to compensate for over exhalation. Aim for smooth transition of inhales and exhales. Once you feel in rhythm with this breath count, you can go deeper into your movement activity. For example, at this stage, I might transition from walking to running, or pick up the pace of going upstairs, or increasing the repetition of weights, etc. Over time, you may try and work to a 2-to-1 exhale-inhale ratio. So therefore, if you breathe in for 4 seconds, you breathe out for 8 seconds. When you feel ready to finish your movement practice, start to slow your pace and breathe down. Be sure to give yourself a few minutes of stillness or stretching and slow belly breathing to let your heart rate go down. So then there's some considerations for the prevention of pain. Fatigue is a common complaint in rheumatological conditions. It can be managed by taking regular micro breaks, avoiding sitting in the same position for long periods, maintaining physical activity, and having a good sleep hygiene. AS patients can suffer from flare-ups of increased disease activity, which can last from days to weeks. During the flare-up, the patient may benefit from gentle stretching exercises, taking breaks in medication. Joint protection management applies to the ergonomic principles to ADL activities. ADL is activities of daily living to preserve functional ability. Patient compliance can be achieved by determining the barriers facing the individual, including the patient's exercise preference in the program, using different exercise varieties to avoid boredom and group therapy. Educating the patient about his condition and how to manage it, besides having a patient-provider relationship, are important for patients self-managing. ADL activities can be made easier using assisted devices and alternative techniques. For example, managing shoes, slip-on shoes can be used instead. If you've got SIJ pain, you can wear an SIJ belt. So these are the types of assisted devices that can help you. So these are the main activities of daily living: bathing, so cleaning yourself, toileting and toilet hygiene, personal hygiene and grooming, dressing, personal device care, feeding, swallowing and eating, functional ability, and sexual activity. So all of these are important for us to feel like humans, to feel happy and functioning to the best of our ability. Then we can also look at our ergonomics. This can cause a lot of problems if we are having computers at the wrong height for our head, if we're sitting too far away from our desk, if our knees are under our desk or foot is under our bum when we're sitting, we are not sitting in the optimal position for our bodies. Then the other thing that needs to be realized about ergonomics, it's not just having good ergonomics, but it's also changing your position. So that's why I've instituted an example here of an ergonomic desk that goes up and down and has 3 positions. It has a sitting position, it has a mid-sit stand position, and then it has a standing position. And if you have the ability to get this at work, definitely go for it, because it can save you a lot of pain in your body. Ergonomics is not just having good posture, but varying the postures we put our body through. When we change positions regularly, we take pressure off some muscles and joints. So other postures to be aware of with sleep is that we can have a pillow in between our knees. When we're lying on our side, we have pillows that are appropriate height for our head, so the head is not dropped or raised. And that we can have a pillow underneath our knees when we are sleeping on our back. We also can have correct posture when we are picking objects up, like a straight back, bending our knees, and bending down. Okay, and that's my talk for the day. Thank you for listening. I hope that it helped you and that you can learn how to manage better your joint and muscle pain. Thank you very much.